You do now. So I'm Pat Kelly. I'm with a Boulder-based firm called Routinify.
Oh, yes. I certainly know of Routinify, yes.
And it's a beautiful, not so hot day, and maybe we'll get some moisture too. So what else could you ask for? And it's Friday.
Yes. So this is being recorded. I just want to remind you, but that's fine. So my air conditioning, I never use my air conditioning. I always close my shades during the day. And of course, I'm semi-retired. So of course, this started when I worked full time, but I still close my shades. And then I have an attic fan that I turn on at night. But I had people over for the first time, I don't know, a week ago when it was really hot. And I turned the AC on and it didn't work. So I'm looking into getting it fixed and we'll see how much that's going to cost and we'll see where it goes from there.
Yeah. But there's probably a waiting list. I have a feeling lots of people are asking for their AC to be fixed.
And I'm getting advice that if I can tolerate it, which I definitely can, I'll probably wait till September because for exactly that reason, which is fine because I can live without it. So tell me your role at Routinify.
So I'm actually the founder and CEO.
Wow. And this is the first time you've joined this call, isn't it?
It is. It's just times and schedules and everything. So thank you very much for the opportunity.
So as you'll see, or as you'll learn, it's completely random. Different people come every time. Anybody who wants to can come, anybody. It's focused on telehealth with leaders from the telehealth world in Colorado. And I started it because I was I still am the Colorado liaison to the Southwest Telehealth Research Center. And I'm the Colorado ambassador to Telehealth and Medicine Today, which is an online peer-reviewed journal. And so they both wanted me to have a monthly get together to talk about SWTRC and TMT. That's at least a year ago. And I'm a facilitator and a project manager, and I led virtual care for Kaiser Permanente, Colorado for a long time. And so I just have a passion for it. But we talk about whatever people want to talk about.
Including billing and reimbursement codes?
Absolutely. And I will admit, especially because I was a KP person for 18 years, that's not my expertise, but everybody wants to know that. And I'm a little disappointed that I don't see other people getting on yet. This is interesting. But oh, here comes Caroline. Good. But that's what everybody wants to talk about, which is fine. We need to figure it out. And did you see the topic for today's discussion?
No, I have not. So I'm a little late coming into the party here.
That's okay. Hello, Caroline.
Hello, how are you doing?
Good. So
Fantastic.
just telling Pat, the founder and CEO of Routinify, about the group because it's his first time joining. We last time, per the group's request, had a guy named, here comes Paul Murphy again, a guy named John Labate join, who's a lobbyist. That's what he does for a living, a lobbyist. And so he joined the call. Hi, Paul. Hi, Paul. Hello, Paul. I can see you. Paul, can you hear me?
Now I can. How are you?
Good. Nice to see you. It's been a while. So I was just telling Pat, who's the founder and CEO of Routinify, but has not joined the call before. I was telling him, and I can tell you too, that Paul, that last time we had this guy named John Labate join the call, who's a lobbyist, and the group talked about various things that we might want him to lobby for us, whatever that means, whatever us means, having to do with telehealth. And we talked about a lot of different things. And so we agreed. And as you guys know, Paul and Caroline, what we talk about is completely up to the group and it's completely random every time. We're going to talk today about, can we find one thing that we agree on as the most important thing that we'd like John Labate to lobby for us with our help as makes sense, whoever the experts are. Caroline, does that sound right?
Yeah, that does sound right, actually. Absolutely, you nailed it.
So Paul, you weren't on the call last month, were you?
No.
Okay. So I have no idea. It's 11:33. How about if we wait another 2 minutes and in the meantime, Paul,
Jan, would you like me to text John right now? I can get him back on the call if you would like.
sure.
Yeah,
Yes,
I'll
Caroline,
text him right now.
absolutely. Paul and Pat, do you know each other?
We have not met. Paul, Pat Kelly with Routinify.
Nice to meet you, Pat. Paul Murphy, lost soul. Just kidding. No, Routinify, very cool. And I spent the last decade, I was with Health One HCA overseeing their telehealth program for the Rocky Mountain region, and saw that, and then they laid me off in 2019. And prior to that, I was with InTouch Health for a few years. You probably know InTouch, who's now part of Teladoc. And then, yeah, prior to that, the stroke registry, and I originally trained as a paramedic eons ago.
And what part of the world are you in right now?
Consulting and looking for which path to take forward. So I'm actually either going to be getting another full-time job or another consulting opportunity. I had 2 consulting contracts in 2020 that were nice, and they were time limited. So I knew that I'd be spending this year exploring options. Good old COVID.
Yeah, and you're in the greater Denver area, I assume?
Yep, I'm by Morrison by Red Rocks.
Pat, all of us are actually, I think. The only people that join, anybody can join, but this is definitely focused on Colorado telehealth. The only people that join from out of state in general are the people from Southwest Telehealth Resource Center and Telehealth and Medicine Today. They're out of state, but this is Colorado telehealth. That's what it's about.
Yeah, understood. I just didn't know if we had people on Western Slope or it was
We
all,
don't.
we're front slope centric. And do we go to Colorado Springs or do we stop, at Highland Ranch?
We don't stop anywhere. It's just the people that I know. That's basically how it started. I reached out to people I knew. So that's the only reason we don't have people from other parts of the state. So if you know other people and anybody, bring them on.
Well, good. We're I'll definitely take up the mantle on that because we started to get some contacts up in Windsor and a little bit further north, and have some interesting implementations going on in Adams County as we speak. So yeah, I'll sort of spread the word.
So Caroline, any word from John?
Not yet. I texted him and sent him over the Zoom link. I'm kind of surprised he's on because he was on. We talked actually pretty in depth after the call last time. I can even give him a call right now too.
Okay. And when you get back on, I'm going to share my screen. You're going to see basically an empty Word document because I'll take notes while we're talking, but it's not working. I'm clicking share screen and nothing's happening. Screen. That's interesting. Oh, I'm frozen, aren't I?
Your video's freezing up occasionally.
So let me take my video off, see if that helps. It's just going really slow, so I'm going to take my video off. And I'm going to open this empty document. Share. Okay. So you can see an empty document. I'm still frozen. And stop video. I'm trying to do that. I've never had this problem. I'm sitting at home, the same place I always sit. So as soon as Caroline comes back, we'll get started. And the topic is what one thing would we like to lobby for? What? You lobby for? Lobby for.
So Jan, just so you know, all it says on our screens is Jan Brown and started screen sharing. We don't see the Word document.
Okay. It should come soon.
And John didn't. answer, but I'll keep you posted if he texts me back.
Okay, can you hear me okay, even though my screen is frozen?
Yes.
Okay,
Audio
Yes.
loud and clear.
can you see the screen yet? My screen yet?
Now we can.
All right, well, I'm still having trouble. I don't know what the deal is. Let's not worry about you seeing the screen. I can tell you what it says. Hopefully you'll see it eventually, because it says on top, you are screen sharing, and it offers me to stop sharing. What one thing would we like to lobby for in Colorado regarding telehealth? And anybody can talk, and you don't have to agree, but the goal is that by the end of an hour, we come up with something, and if you are the only 3 that participate today, you guys and me, obviously, we get to decide. What do you think? Anybody?
Love it.
So,
Sounds good.
All good, thank you.
what do you want to lobby on? What are you thinking?
I'll go first. So there's certainly a lot of work to be done around delivery in a skilled, quote, skilled care environment. But I'd like to see it in the, non-skilled areas as well. Another way to articulate that would be utilization for preventative and lifestyle activities. I mean, the industry, from my perspective, is always kind of break fix. So let's wait until somebody has a severe chronic condition or otherwise, and then we have great tools, be it telemedicine or remote patient monitoring and others. And there's certainly lots of work to be done in that regard. But let's try to be preemptive and allow the same tools and the same processes to be applied prior, in a lifestyle medicine or a preventative care standpoint. Let's allow them to reduce the cost of providing in-home care, as just differentiated from in-home health care, by removing the requirement for minimum hours, travel, all the inefficiencies of having scheduled physical, relying 100% on scheduled physical care, as opposed to having a data-driven demand care where some of that demand may be satisfied through virtual care. So just moving our telecare from medical clinical only into lifestyle and preventative, and improving the efficiency of in-home care providers. That was a mouthful, but I'll step off the soapbox.
So thinking about that for lobbying, I'm guessing that you're saying and have this reimbursed. Is that what you want would be lobbied for?
Correct. Yes. And one can make the argument that expanding care coverage actually will do 2 things. It should reduce have an overall reduction in long-term care costs, obviate the requirement for admissions or readmissions, but also ideally reduce the total cost of care over time. So yes,
Good. Other
reimbursable,
people?
please.
Can you see my screen yet?
Yes, absolutely. It looks
Okay,
great.
Okay, other people, what are you thinking?
Are we limited to one thing? And the reason I ask is if you pick one thing out of this entire world of telehealth, it's the ocean versus boiling water.
So we are absolutely not limited to anything. We can do whatever we want. It will always be my suggestion, just as a project manager personality, that if we are more focused, we are more likely to get something done. But right
Sure.
now, talk about whatever you want, and then let's see if we can. It's just a question of getting something done. So no, we're not required to do anything. What are you thinking, Paul?
I'm thinking you've got buckets. You've got from the payer side of the insurance, the Kaisers of the world. You have the healthcare system aspect. You have the vendor aspect. You have the policy folks, and then you have access. And I agree with what Pat said. All those points right there, I think, are huge. And I think access to care, and the big thing is value-based care, continuity of care, I'm just rambling here. Just if you're going to legislate something, what do you legislate for? Well, you want smaller footprint hospitals. You want to leverage patient at home with dispatch help type models. And if you're going to legislate one thing in the state of Colorado, I don't have an answer. I'm just speaking out loud here as I go through all the factors to consider here as well.
So again, Paul, when you, just like you, it helps me to think out loud, so I get that totally. So as you're saying all those things, is there anything like if you had a state senator or a representative in front of you or the governor, I really want you to change X, or I really want you to do X. What are you thinking ish?
So don't wind back what they did with COVID relaxation. So they made progress relaxing the rules, so don't wind it back. Related to that is promote physician reimbursement across the board, regardless of service line. Because if you get access that, so reducing the COVID stuff and, keeping the COVID, loosening of the rules, et cetera, regulatory stuff, keeping that in place allows for greater access, and getting physicians get reimbursed, et cetera. I think those two marry to each other, because that would ultimately also hit Pat's world with Routinify for reimbursement as well, if I'm not mistaken, Pat. Feel free to jump in on this one.
No, I know where you're going. I concur. Yeah.
And so I kind of know what you're talking about, but again, let's try to be as specific as we can. So, and Caroline, we haven't heard from you yet. And you were the one that introduced us.
Yes.
John, I would just say, let's talk about the specific COVID rules, but Caroline, you go first.
Yes, no, these are things that I all agree across is, I mean, I don't think we should roll back anything from COVID. That is huge. I think we've seen, I mean, I want to say in Colorado, it went from 19% of people who are doing telemedicine to now 78% acceptance. Not that every 78% of people are actually using it, but I think that that's a huge skyrocket and is only going to increase. So if we roll back anything in terms of access, that's just a really bad idea. But then too, it goes back into reimbursement and again, improving access, because not everyone does have the infrastructure in place to do telemedicine. And typically those that are most at risk are the ones that need it the most. And so again, I think we're all in the same zone of what we, think is important. I think it's now just kind of really breaking it down to the specifics of what does that actually mean.
So one thing that I'll put out there, adding to what Caroline said, and I don't think I'm an expert in I'm just facilitating this. So I think I know less than you guys on what's most important. But from everything I've heard, I would suggest that maybe the most important thing, more important than reimbursement, maybe, is to figure out how we get broadband to everybody in the state. It's just a suggestion.
And that's a huge theme that we're seeing right now across the board, from education to working from home to telehealth. I think that is a really important thing just in general. I want to say there could be something on the books because Colorado has been talking about that.
Yeah, I just want to make sure that we're not replicating or because there are federal and state initiatives in that area. There very well could be gaps, and Paul, you may or may not be closer to it, but I do know that at the federal level, there's various FCC initiatives primarily for rural areas, and I don't know the details of the state initiatives, but I think they too are targeting primarily rural. But I also heard that people have really realized that lack of broadband access doesn't necessarily mean rural. You can be in the city and not have access just because you can't afford the infrastructure. But we should make sure that we're consistent with any other initiatives that are going on currently at the federal state.
All right.
Dan,
So
you might want to reach out to Office of eHealth Innovation at the state, because they are over the ups of OIT, because they, at least last year, they had a broadband task force up and running. that would addressing the specific topics for the broadband connectivity aspect.
Okay, so let's now, and I'm sure John Savage will know, I'm guessing, Paul, that John Savage will be up to speed on that probably. But we can find out. I
He
can
was
find out.
involved as well.
So let's talk about the COVID rules and think about the rules that came into place. I'm not responding, whatever. So I'm kind of talking slowly till I can type again. The COVID rules that are in place that you want to make sure are not turned back. You don't need to think about the most important ones. Let's just write down what they are, and then we'll talk about if it were up to you, which is the most important one to make sure that doesn't go back, second most important, or we can do a vote or something. Anyway, what are the COVID rules you want to make sure don't go back?
I think broadly speaking, you had lessening of restrictive access. So access was enhanced, or however you want to type it. So reduction of restrictions is one.
So what kind of restrictions though? What do you mean?
With regards to how telehealth could be used, so it's platform based, it was also reimbursement based, and what service line it could be based. I think those are the three, because it was technical, clinical, and financial.
Okay, hold on one sec, because I want to go into more detail with this. Paul. Okay, so platform-based, meaning we didn't have to do it on a HIPAA secure.
Technology based, yeah.
Are you talking
I
specifically?
mean, the reality of it is, go ahead.
No, you go ahead.
So if they're going to wind anything back, I would say of the three, type 1, 2, and 3, number one, just have providers use a platform that is HIPAA compliant, because that still allows a lot of the vendors out there to be happy. So I think that's something you could wind back, because you don't need people using FaceTime, et cetera, for it. Service line from a
Hold on.
clinical line.
Wait. I want to make sure I understand. Are you suggesting, what I understand, and again, you know this better than, what I understand is, actually I know this, the doctors have been allowed, not just doctors, but I'll say doctors. Doctors have been allowed to use non-HIPAA compliant platforms for telehealth with COVID. And are you suggesting they should keep it that way so they can use any platform that does not need to be HIPAA compliant?
I would say that of the three, if you're gonna have something that's gonna get wound back, let number one be wound back where they have to use it versus just using whatever platform they want.
Okay.
Not everyone will agree. I'm just, if you had to die on a hill, die on technology.
Okay, go on to the next one.
Service line, any
Yep.
clinical service line should have access to telehealth, period.
And what was before COVID?
You didn't have all your service lines having access, because you had people dabbling their toes in it and realizing, I'm trying to think if there's any service lines, clinical service lines that were specifically not using telehealth, but I think it should be applicable to any service line. The other nice thing to consider here, should have access to any telehealth, yes, and then potentially remove the need for in-person.
Finish the sentence.
Before
Remove
use
the need for
telehealth.
in-person.
Remove the need for in-person prior to telehealth session occurring.
Okay. Just going to number 2, I can only speak to, I'm talking about outpatient. I'll admit that I'm an expert in outpatient, and certainly every specialty at KP Colorado had the opportunity to provide care by telehealth before COVID. I know KP is different, but so can anybody think of a service line that it was not allowed pre-COVID to provide care by telehealth?
I'd have to defer to like John Savage in that area. So unfortunately, he's not here, but he knows the details there.
I'm closely in touch with them.
I agree with Pat.
Okay, so definitely that sounds like a big one, number 3 that you just said. And now obviously the reimbursement, this is probably everything. So talk to me about what changed with COVID that you want to make sure does not change back. Start babbling.
The last I heard, meaning the payers and the feds, were allowing physician reimbursement for services provided through telehealth. So when they opened up access to telehealth, they also opened up the reimbursement aspect for telehealth. And the rumblings that I've been hearing is that if they start bringing the access back, winding it back, payers are going to look at this as well. So I think under the reimbursement base, I think one is any service line should get reimbursed, and two, with parity, should be reimbursed as if it was in person. So yeah, parity, those are the two things that I would take away from it. I think Pat would have perspective from Routinify.
I can think of another one. Originating site. Where the patient had to be at another clinical site. Was that true pre-COVID?
I think based on geography and clinical line, I think that was the case.
So geography needs to be, doctor needs to be licensed in the state in which the patient is located physically. I know that one well. That's what you're saying, geography? Is that what you mean?
Well, and where the patient's located as well. Urban
That's what I mean.
because historically they didn't want to do telehealth. Yeah.
Right, I know that one well, because I'm on the interstate committee and the APA. Doc must be licensed state in which the patient is geographically located. But the other one, and again, I'm not as familiar with this because KP had an exception. But is this true pre-COVID? I'm asking everybody that the patient had to be at a clinical location. They couldn't be at home in order to get telehealth care from a provider at another clinical location. Is that true?
I think it varied by state and by service line.
Caroline, Pat, do you know anything about that?
I am not sure the specifics on that one.
Again, I'd have to defer to, a practitioner provider that would know the.
That's interesting. You know what? I'm feeling like I think I do know a lot about this then, because I'm pretty sure that's the case. Pre-COVID, patient had to be, we can confirm this, but I'm pretty sure this, I know more than I thought. Patient had to be at another clinical site pre-COVID. During COVID, patient could be home or anywhere. So I'm guessing that this is the most important one. And I will add to this, and I am radical, and I know I'm radical, and you may not agree with me, and absolutely say so, and I do not have veto power. I don't think it necessarily should be parity. I think because video visits in general are shorter than in-person visits. So I think that if I were to write the law, I would write something along the lines of, by law, clinical people must be reimbursed for care provided by video. I assume we're talking about video. In a time parity process. I'm making up the words. Okay, everyone, what do you think of what Jan just said? And you can completely disagree with me.
Well, that time parity, I don't want to speak for John and others, but I know that that's a big deal because a lot of times you get a giant haircut. A lot of the reasons people don't want to do telemedicine and RPM is the rates, do not correspond with or consistent with office visits. And you'd expect them to be more efficient. I guess we have to define what effective means. But I know that's a rub with a lot of people. The reimbursement rates are so low, it's just not worth their time to get involved.
But suppose a doc, and actually, again, I'm pretty radical, and KP thinks I'm radical too. I'm more radical than KP. I mean, I think KP docs are salaried with bonuses based on clinical outcomes and patient sat. So it's not even relevant. But docs in the fee-for-service world, I think they should get reimbursed for care by email, by text, by video, by phone, by remote monitoring all of it, which obviously they don't get for phone or email. We can go back to phone, but certainly not email. But I think it should be time-based. So if you spend 1 minute for email, and I'm making this up, and 5 minutes for phone, and 10 minutes for video, and 20 minutes for in-person, I think the reimbursement should be approximately driven. And I'm not saying that literally the doc should time them. I'm just thinking if we could come up with, on average, docs spend the most in person and the least time by email. Okay, I want to hear from everyone. What do you think about that?
Well, I agree. I'm hesitating because I think that, the people that would be the strongest voice and advocates are those on the receiving end of this. So the practitioners, providers. But my understanding, this is one of the big rubs is there's not the same value proposition, or it's not clear. And particularly if you're going to augment your in-office model with virtual care, that doesn't come, free and easy. I mean, you've got lots of, training and internal logistics, and, it's just a lot of stuff to do. And you look at taking a big haircut on your interactions with your patients, you just, no, thank you. So I think that's one of the strongest reasons that more offices are not adopting it, is there's just not the proper payback. Now, of course, you have people that are building business models where they want to leverage that, and to wit, what's happening with mental health. I don't want to open up the can of worms about cross-border mental health delivery, but you have people that are finally tuning their business models to be 100% around virtual care delivery, and the numbers can work out a little bit different. It was a long way of saying yes, and that people need to really be thinking specifically about the metrics involved there.
Oh, what are you thinking?
Exactly what Pat just said.
Okay.
Yep.
So I assume, and Caroline, what are you thinking?
Oh, I'm completely in agreement. Yeah.
So certainly I'm sure are unanimous that all service lines should be reimbursed for care by video. We all agree on that.
Yes.
And so I'll ask then Pat and Caroline, what do you think of Paul's opinion? And if you all three agree, then I'll go with it, even though I don't agree, but I'll go with it. Majority rules that telehealth care by video specifically should be reimbursed with parity to in-person. Do Caroline and Pat, do you agree with that?
Yeah.
Yes, and I think as this takes finer detail, it's going to beg the how do we define parity. But as a concept, yes. And then I think to turn that into actual policy, we'll need somebody will need to distill it down into what does parity really mean. Is it minutes parity, or is it the delivery, the actual care function? I mean, you could be on both sides of that. It's like, if I'm getting paid to intervene around a specific hypertension event, should I be paid for the intervention, whether or not I've fine-tuned my model that I can do it in 2 units at a time as opposed to 3 units at a time? Or is the reimbursement specifically around the mode of delivery? You see, and at some point, when this gets down to a policy, it's going to just, we're going to get down to that. Is it, what are you getting reimbursed for? What you've delivered or how you delivered it? So I agree that that video delivery should not be excluded, which it currently is, but we also probably need to think about the unit of measurement, and the unit of measurement being strict time that may be, you can argue both ways, that if you're able to deliver more effective care, you should be incentivized to do that, and time may not be the perfect metric for doing that. the care that you're delivering is the metric. That's where I'm going. But that's probably a level of detail we don't need to address right now.
So I'm gonna guess that of these 6 things that I have listed here, number 4 would be number 1.
Let me zoom in to make sure I can view number 4. Reimbursement based, all service lines should be reimbursed for care by video with parity. Yeah, and parity, I think we can leave parity. I think we do ourselves a disservice if we define what the underlying metric that parity is. Parity is the operative. We can get into the details at some other point.
So again, I want to hear from all 3 of you. If we're going to come up with the most important thing that we want John to help us lobby for, I'm guessing that making sure that care by video continues to be reimbursed with parity to in-person. I'm guessing that. And so I want to hear, do you agree with that?
I think of the 6 you have listed, yes. And I think number 4 is the one to do. And I'll say, even though I know you're already going to do this, good old Dr. John Savage, see what his thoughts are on this list. Because my gut says, I mean, it's one of those things of, if you don't pay the docs, they're not going to do it or reimburse them. And to Pat's point, defining it is going to be a can of worms that's going to exceed the time we have here.
Absolutely.
This is Colorado State. So the other, yeah, and you may want to touch base with when you talk to Ojai about the, where is it up here? Broadband Task Force. You may want to ask Ojai about what their priority policy is, because they may have a similar list that they're vetting out. And my guess is that they're making progress on that list with HCPF, which is Colorado State's Medicaid.
Okay, so Paul, let me get this right. I'm assuming what you're saying is find out what they're doing so we're not being redundant. Although John might, I don't know anything about lobbying. John might say, we're just another group to push the effort. That's a good thing. I have no idea.
Yes, I would agree.
We have providers, and I'm trying to think how we would differentiate ourselves. We don't work for the state. I guess that's the main thing. We don't work for the state.
No, but if the state has, like, if Ojai has initiatives, or the state's Ojai reports into the monthly state group that gets together. I'm drawing a blank on the name of them. That group that has been given an assignment by Polis to do activities. I believe that there's some of these COVID rule items we have here that they are tackling. So Ojai, I would type in next to Broadband Task Force. I would just type in current legislative efforts as well.
That I would
Ojai,
that I would find out from Ojai. What?
Yeah.
Do I have it right? Is it OEHI? Is that right?
It's, yep, correct. Office of E-Health Innovation.
That's right. I used to be involved a little bit. Okay, so you commented that you think 4 is the most important to focus on of those 6. Is there other things you can think of besides making broadband available to everyone in the state? And then this list of COVID rules that we want to keep the same. Are there other things we want to think about that we might want to have lobbying for that's not listed yet? Caroline, what are you thinking?
Nothing that's not listed. I mean, because I think that a lot of them too kind of do go hand in hand, but I think focusing again on, paying the practitioners, that's going to be a huge driving force into the rest of it. A lot of them do kind of go hand in hand and kind of play with each other. But I think that, focusing on the reimbursement aspect will be a driving force into, again, increasing across the board from practitioners to actually the usage and access. Yeah. I think the reimbursement.
I'm going to put out there this is my opinion, but I don't think we're gonna disagree a lot. If I had to pick the second and third most important of these six, it would not be number one, like I agree with Paul. It would be number 3 and number 6. Those two would be, those two would be the next most important to me. What do you guys think would be the next most important?
Yes, I think number 3 is definitely very critical, because without that piece, again, it just makes more barriers to entry. And also too, I agree with 6.
What do you think, Pat?
No, they're all kind of interrelated. So you can take a risk that if people are really buying into telecare, then of course you're not going to have to do an in-person one. But having said that, this is policy. And I think that's another blocker that, for people that maybe have all sorts of other challenges around receiving in-person care, that can be a big blocker as well. So one would lead you to believe, oh, gee, it's obvious that 3 has to be part of 4, but then again, obvious is not necessarily the mantra here. And if 3 still remain in place, it serves as a fundamental block, particularly in the aging adult. For this to move deeper in the aging adult space, that's a huge block. How do you actually physically get there? And once you solve the logistics, people just don't want to do it, or they don't want to take the time to do it. So long way of saying, yeah, 3.
Okay, and then number 6, I just can't even believe they would go back on this one. It's hard to believe, but who knows? I don't know how the law works. Do you remember that people had to be, like, if you were getting, it was all for specialty care, obviously. People would get a specialty video visit to go into a primary care office close to them. And that was required. KP had some national agreement. This is when I started it 6 or 7 years ago. We had a national agreement that we didn't have to do that. And I just shook my head like, why does everyone else need to do this? So does anybody know anything more about that? I can check with John what he knows too. Okay, I'll check in. So I think the things that we've talked about that are most important, I'm going to highlight them in yellow first. Yellow, let's see, home, see if I can do this. Home, yellow, this one. These. And this. And I just want to make sure I haven't heard much talking about number 6. Is it because you don't even remember when that was required, or you don't think that's as important, or you don't agree with me? I just can't believe we will ever go back to a place where people can't get video visits from home or anywhere else in the state. What do you think about number 6?
Yeah, I can't imagine if they go back on that, because that literally, just goes against since COVID, now our version of, telehealth is not in a clinical setting. So I can't imagine they go back on that.
So I think I'm hearing you say, Caroline, that you think that's really important, but you don't think it'll be an issue.
Yeah, I can't see them
I agree with you.
going back on that. If they did go back on that, that would be a really big barrier that would drastically impact 3 and 4.
I agree. Paul, comment on number 6?
Agree.
And Pat?
Yep, I'm there. I think
So
even
just-
the VA is moving away from that. That's kind of a vestige of the original way that telehealth was delivered in the VA.
Absolutely, yes. Yes, absolutely. I would say KP led the way with telehealth, except for the VA. And so therefore, the VA was doing where you had to go to a clinical site, and KP, I think, was the first, at a big level, certainly, that you could be anywhere in the state in which your doctor is licensed to practice medicine. But VA definitely started the whole thing. So I just want to tell you a couple of things from other people that said they couldn't come to this meeting, but I said, do you have any thoughts on what we're going to talk about. This is from Susan Peralt. One of the areas I was thinking of is transportation in the rural areas versus bandwidth for telemedicine appointments. The concept is utilizing facilities or buildings that already have great internet and bring the person to this location for appointments. And then she wrote, secondly, is reimbursement for store and forward, as well as other telemedicine appointments once COVID-19 is complete. So let's add that. Any comments on what she said, the first one? So she's suggesting reimbursement for transportation where there isn't broadband.
Yeah, my first reaction is if we limit broadband to being, you know, cable services and physical, you know, long-term physical connectivity, well, you know, mount and all that, then that certainly is an issue. And I'm not saying that Colorado has ubiquitous cellular data or LTE data, but I would much prefer to see subsidies for LTE data so that people can still, you know, receive the services in their home.
What does LTE mean?
It's just another word for cellular data.
Okay.
So
Just how you know everything works on your smartphone that can be available for tablets and other devices. So I don't see that we have to be limiting broadband access definition to be just cable only. I think if that gets opened up and people are looking at it more broadly, that where cable access is not appropriate, cellular data access is definitely I mean, certain mountain communities where both are a problem, but if you look at the state of Colorado, LTE coverage is quite extensive. And this is not Colorado yet, but I'll just give you an interesting example of this. We're doing a deployment in Canada for long haul truckers, trans-Canadian truckers. And there it's all LTE service because our telehealth and telemedicine is being delivered to the truck. Not that they're having a telemedicine show, at least hopefully they're not driving down the road. They're, you know, pulled over, they're in a facility, but they're, you know, just that redefines, you know, A, mobile, and B, what broadband access really means. And so that could be readily translated to rural Colorado. So I would be more, let's get the data to them. The other thing, and again, I'm back in my soapbox, but if you're transporting the person just for a telemedicine visit, then you send them home. You're back in that whole post-discharge scenario. What did you do? They had a telemedicine visit. Somebody printed out something on a piece of paper, and you're going to take them back home with the piece of paper. So telemedicine needs to extend beyond just that intervention with the clinician. Telemedicine needs to be there to help you be successful with those activities. So again, I'm not wild about the transportation because it doesn't deal with the pre and post visit. It doesn't deal with, on the pre side, hey, I should be getting information about how you're doing, whether it's vital monitoring, interacting with you throughout your period of time at home about how you're doing, and symptom checking prior to you getting in a van and showing up to have a 15-minute telemedicine session. All right, I'm stepping or falling off my soapbox.
I agree.
yep.
So you see that I moved it up here. I totally agree. And maybe this is while they're fixing broadband, just while they're waiting for it, but not to make that the focus, I guess. And then she also wrote reimbursement for store and forward. And then Dan, this is definitely me, these last few. I think there should be reimbursement for everything. I don't see that happening. I mean, so, and actually we haven't talked about this, but what about reimbursement for phone visits? What, I mean, that actually, that is a COVID thing. And I assume it's going to go away, which I don't agree with. And I think that's a big one. What do you guys think?
I would love to know the stats on that. Because of course, this is just me being, because I've done many, honestly, COVID is now like, I've done many different doctor's appointments in the times of COVID virtually, and like, I'm obsessed with it. But I've never done it over the phone and like missing the video aspect of it. I think it gets interesting based on what's wrong with the person, because at some level, seeing something, there is definitely some validity to it helping. I wouldn't put a priority on it. I would also like to be very intrigued on the stats on that. How many
You
people
said
actually
you
use
would
it?
or would not put a priority on it?
I don't think I would. I feel like you could easily kind of bundle it into one of the others. Because you can do telehealth on your phone for the most part. So if you're calling in, you know,
So I'll give you a different point of view. And again, I'm radical. Especially if not everyone has broadband. But I think it's fair to say that everyone in the whole wide world in this country has a telephone. I think, even if it's a home phone, landline.
Yep.
I have osteoporosis. I've told the story a million times. I'm 64 years old. I have osteoporosis since menopause, 14 years. I have gotten care from an endocrinologist. She has never touched me. There's nothing to see. There is nothing to see. In fact, I have a phone visit with her next week. She did her very first video visit with me, I don't know, 8 years ago. And that's probably the only one she did pre-COVID. And her medical assistant asked, do you want us to come in person? No. And she said, do you want by video? And I said to her, I think phone is fine. I mean, this doctor knows me well. There's
Yeah.
nothing to say. So why?
that actually makes a lot of sense. No, okay, now, and that actually, I think the parity piece on that is important then. That makes a lot of sense, actually.
Yeah. We should just have it as a derivative of, you know, it's voice and video. I mean, voice is a video call without video. I mean, but to your point, we should definitely make sure that it's called out. And I need to apologize. I'm unfortunately a host for another session at 12:30 that I need to prep
Okay.
for. So I
Thank you for
apologize
joining, Pat.
for dropping.
I think
Thank
we've got what
you.
we need.
Thank
I'm
you
going to
so
reach out to Pat, and I'm going to talk about Caroline with Caroline and Paul right now for the rest of the 5 minutes of what do we want to do next. Beyond this, I mean, I can tell you what I will do. I will talk to John Savage, and if he agrees with what we've come up with, then with Caroline's help, I'll reach out to John Labate and see where we go from this. And the other question I have for all of you is, what do we want to talk about next month? Pat, if you need to run, that's fine.
Great. Thank you.
Thanks
Bye
for
now,
coming.
everybody.
And of course, I'll always ask, there's only a few of you this time. I did hear from Ted Pauline and Susan Peralt that they couldn't come today. I think, John, but if this is not a good use of people's time, say the word, we'll stop doing it. I really mean that. I won't be offended. I just want you to know that. So having
I
said
think it's great.
that, do you want to meet again? And if so, what would you like to talk about at the next meeting?
I think probably going through this with everyone else again, probably getting John on. And then, I mean, it kind of depends too on the feedback that we get from John Savage, and then getting kind of John Labate's feedback on what he thinks next steps look like. Because I know for him, as long as he knows like really specifically kind of nitty gritty what we want to achieve and accomplish, then he like walks us through kind of the next steps and what that looks like. Or like what he would end up doing. So
That makes sense.
Yes.
So I'll talk to John. I'll talk to both Johns. Hopefully I will, I'm saying this crudely, but I'll get especially John Labate, but hopefully both Johns to commit to being able to come to the next meeting or even reschedule if we need to, because it seems like you guys think, and I agree with you, that John Savage is critical in this conversation because he's a doctor and because of his relationship with the state, I'm guessing. Anyway, I'll make sure they both can come to the next one. And if by any chance, we don't need to talk about this because everything's moving, which I doubt, then we'll just get everyone to give inputs, give updates. How's that?
yeah, that sounds perfect.
It works.
Anything else you want to talk about?
Good right now. This is looking
Nothing
good.
here.
Nice to see you all. Thanks for joining, and I love doing this as long as everyone else does.
I love it. No, Jan, thank you so much.
You're welcome. Makes me happy too. See you guys.
See you.
All right. Enjoy your weekend. See you. Bye.
Bye.